Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our Pediatric Critical Care Fellowship webinar. We have a very special webinar today. And as you know, we have started our Module 2 of the Pediatric Critical Care Fellowship. And each module, you will have weekly lectures recorded in a smart platform with MCQs, clinical case scenarios, didactics, clinical based discussion, and the journal club with also multiple choice questions. We have close to 200 fellows from 32 countries, and we have very successful Module 1 that we finished a couple of weeks ago, and we just started our Module 2. So Module 1, we were focusing on classification of different kind of shock, pathophysiology, transport of critically ill children, and stabilization, various infectious diseases, and septic shock, and nephrology critical care. In Module 2, we are trying to give you very up-to-date information about neurocritical care, traumatic brain injury, hypoxic and ischemic brain injury, status epilepticus. Then the second mini module will be focusing on respiratory critical care. Then the last part of Module 2 will be dedicated to cardiovascular critical care. In Module 3, we will be focusing on nutrition in critically ill patients, point of care ultrasound, endocrine metabolic disorders, oncologic and gastrointestinal emergencies, and urgencies in children. Also, we have very good news for you that we are planning to start a pediatric cardiology fellowship online, wholly online, 3 modules, 16 weeks each. So it's a total of 1 year. So we are structuring this fellowship, and we are planning to start it in a couple months from now. If you are interested, please go ahead and apply. We are going to add and share the information in the chat box, and you can get 15% discount if you apply for this pediatric cardiology fellowship this week. So upon completion of this fellowship, you are expected to be an expert in the field and to be graduate to at renal and mental level and to receive American Association of Continuing Medical Education graduation certificate. Without further ado, we have a very special webinar today. We are focusing on mastering ventilator troubleshooting in critical ill children. And we have great speakers, moderators. We have Dr. Turki Al-Atibi, who is a very active board member in our Pediatric Critical Care Fellowship. He is a pediatric critical care physician in Saudi Arabia, and he's going to moderate the discussion. Dr. Ali from University of Southwestern Dallas, Texas, is going to give us a case-based discussion. And our guest speaker is Dr. Raed Sadiq, who is going to take us in a journey with how to take care of the ventilator and to do the troubleshooting and alarms on the ventilator. And we have Dr. Jones Matthew, short, brief presentation as well. So very exciting webinar, and I just want to give you some information. If you want to get the transcription with different language, so whatever we are saying in the webinar, it will be transcribed on your screen. You can activate show caption from here. You can just click show caption, then you can see the subtitles with different language, whatever the language that you will choose. The webinar will be recorded, and we'll share with you the recording in a couple of days. And all of you should receive attendance certificate this week as well. With that, I'm going to let Dr. Turki Al-Atibi to introduce Dr. Raed Sadiq.
Thank you, Prof. Amr. It is my pleasure to introduce Dr. Raed Sadiq. He's a friend of mine. He's pediatric intensive care consultant in King Fahd Medical City and Second Health Cluster. And he is also the head division of PICU in Yamama PICU and senior lecturer at Imam Muhammad Ibn Saud University. And he will talk about the troubleshooting in the ventilator. Welcome, Dr. Raed. The floor for you.
Assalamu alaikum. Good evening, everybody. It is my pleasure to present this important topic about ventilator troubleshooting. Ventilator is a smart machine. However, it is like any other machine, can be exposed to multiple problems related to its software or hardware problems. Ventilator troubleshooting in general could be due to patient-related problems, ventilator-related problems, or mixed problems. Regarding patient-related problems could be due to airway problems, secretions, dynamic hyperinflation, and bronchospasm. Ventilator-related problems could be due to leaks, inadequate oxygenation, trigger sensitivity problems, and auto beep. Mixed problems, which are the ventilator-patient asynchrony. What do we mean by ventilator-patient asynchrony? It is a mismatch between patient respiratory drive and ventilator-delivered breath, and could be due to trigger or cycle problems, which I will explain in the coming few slides. How to approach ventilator troubleshooting? We can simply use ABCDE method. The letter A, first thing you need to assess your patient, look for distress, any cyanosis, chest wall or chest movement equality. The letter B, you should auscultate and listen to breath sounds. As they are absent, any additional breath sounds like wheezing or crackles. Then the letter of C, check the circuit, the ventilator circuit. Is it connected? Any kinks in it? any water accumulation. And the letter D, the device, which is ventilator, you need to check the software of the ventilator. Look to the mode, is it correct? Look to the pressure, volume, and flow waves and loops. And lastly, the letter E, evaluate the lungs by blood gas or chest x-ray or ultrasound if needed. As we mentioned, that ventilator is a smart machine. It gives you alarms when there are any problems. So the ventilator alarms could be high pressure alarm, low pressure alarm, low volume, high PEEP and low PEEP alarms. For the sake of the time, I will concentrate on two important alarms, which are the high pressure and low pressure alarms. So high pressure alarms means that there is high peak inspiratory pressure. And the peak inspiratory pressure is the pressure generated by the ventilator to overcome airway resistance and alveolar resistance. So the peak inspiratory pressure composed of two pressures, the airway pressures and the alveolar pressure. The alveolar distending pressure, and sometimes called transpulmonary pressure, is the plateau pressure that we measure it in the ventilator. How we do that? By simple maneuver called inspiratory hold. Usually the airway pressure is very minimal, is less than 5. When we do inspiratory hold, so we can differentiate between the peak pressure here and the plateau pressure, and in between is the airway pressure. So how we do inspiratory hold? This is the servo I machine. The button of inspiratory hold will be here, and next to it is the expiratory hold. So if we have high peak pressure but normal plateau pressure, normal alveolar pressure, this means that the airway pressure is high, and the problem it is in the airway resistance. So airway resistance related issue like biting, ETT, small ETT, circuit kink or circuit fluid, in addition to ventilator asynchrony, mucus plugs and secretions, and lastly bronchoconstriction. If we have high peak pressure and high plateau alveolar pressure, this means that we have compliance issue, and it could be due to pulmonary edema, atelectasis, autobeep, pneumothorax, abdominal compartment syndrome, or ETT in the main bronchus. The second alarm is low pressure alarm, and usually it is combined with low volume alarm, and commonly it is due to leak, and the leak could be from the ETT to the last point in ventilator. And so the leak could be air leak, airway leak, circuit leak, or if the patient have chest tube, could be a chest tube leak, or there is patient Y-piece disconnection, or the sensor of the ventilator is loose or disconnected. So if we got a low pressure leak, we should look, if we got a low pressure alarm, we should look to the volume time scaler, then followed by volume pressure loop and flow volume loop. So this is what we call it for volume time scaler. We look to the inspired volume and the expired volume. If the expired volume is less than the inspired volume, so this could be due to leak or could be due to air trapping and auto beam. So the next step is to check the flow time. Why is that? Because we can differentiate auto beam and air leak from the flow time scaler. So this is the flow time scaler. We can see that the expiratory flow is not coming to the zero baseline in case of auto beep. However, in the air leak, it will go to the baseline. The second, we should look to the flow volume loop. In this loop, we can see the expiratory flow is normal. However, the expiratory flow does not go to the zero baseline here. In the air leak, the inspiratory flow is normal. However, the expiratory flow is deficient and not equal to the inspiratory flow. This is what we can see in the real life screen. Here, simply we can see the tidal volume, inhaled tidal volume in this example is 450. However, the exhaled tidal volume is only 98. So the rest is leak. And why we said it is leak? If we look to the flow time scalar, we can see the expiratory flow goes to the baseline. This is the pressure, this is the flow, this is the volume. And we can, as I mentioned, we can look to the volume pressure loop and we can see the inspiratory volume is normal. However, the expiratory volume is deficient and not equal to inspiratory volume. This is the real life screen, how the leak looks like. If we got air leak alarm, usually it is associated with low exhale tidal volume, low minute volume, low airway pressure, especially if volume controlled mode, low beep if the leak is sizable, and the patient will have high respiratory rate and tachypneic if auto trigger. The auto beep, simply we can figure it out by looking to the flow time scalar as I mentioned, and I will give you a real example in this video when the auto beep can be confused as a leak. If we look to the volume time scalar, we can see that the expiratory volume is less than the inspiratory volume. However, if we concentrate in the flow time scalar, we can see that the expiratory flow is not going to the baseline as I am pointing here by my finger. So this is the classic example of auto beep, and it is due to too prolonged inspiratory time, 3.9 ratio to 1. So there is inversion of the IE ratio due to too long inspiratory time and too short expiratory time. So how to measure the auto beep? We do a simple procedure, simple maneuver, which is again expiratory hold for 3 to 5 seconds, and we look to the screen. In the screen, after we did an expiratory hold, we will get total beep. The total beep in this example is 28. However, the set prescribed beep is 5. So the auto beep or intrinsic beep is 28. Subtract from 5, it will be 23. So auto beep or intrinsic beep, it occurs when the airflow does not return to normal or to zero at the end of exhalation, and this will lead to breath stacking and dynamic hyperinflation, with a portion of each subsequent tidal volume may be returned in the lung, leading to ineffective trigger or wasted effort as type of patient ventilator asynchrony. The causes of auto beep commonly is obstructed expiration as in bronchiolitis or bronchial asthma, or iatrogenically if we are giving high minute ventilation with excessive high respiratory rate from the ventilator or large tidal volume, or in the previous example if we set the inspiratory time too long with short expiratory time and leading to IE inversion. And lastly, it can be due to excessive demands by under sedation or pain. How to manage auto beep? If it is due to bronchoconstriction, we give a bronchodilator. If it is due to excessive minute ventilation, so we should decrease the ventilator rate, we should decrease the tidal volume, and we should prolong the expiratory time and shortening the inspiratory time. And if it is related to respiratory demand, we should treat the underlying pain or under sedation and fever. Now we will go to patient ventilator asynchrony, but before that I would like to emphasize about these important basic knowledge. Each ventilator breath consists of 3 factors: trigger, control, and cycle. What start the ventilator breath is called the trigger. What limits or deliver the ventilator breath is called control. What ends the ventilator breath is called cycle. Another important, sometimes confusing concept, the sensitivity and the trigger. In ventilator, the low sensitivity actually means that the ventilator is hard to trigger. Why is that? Because the common trigger we are using in ventilator is a flow trigger, and the ventilator provides a constant bias flow, so the ventilator triggers when the flow drops by a set amount. For example, if we set the trigger 5 to 6 liters per minute, this is hard for the patient to trigger. Why? Because the patient needs to generate a flow drop 5 to 6 liters, which is too hard for sick patient to trigger. So if we use 1 to 2 liters per minute trigger, this is easy for our patient to trigger the ventilator and give a ventilator breath. Ventilator patient asynchrony or dyssynchrony is very common, and it is estimated to occur in at least 50% of the patient who receive mechanical ventilation for more than 24 hours. And it can be flow problems, trigger problems, or cycle problems, but I will concentrate on the most common problems, which are trigger problems, namely double trigger and ineffective trigger. So what is double trigger problems? It simply occurs when the patient inspiratory time is more than the ventilator time. So the ventilator inspiratory time is shorter than your patient time. What this will lead to? This will lead to a second breath triggered before the patient doing exhalation. And this will lead to 2 breaths back to back without expiration in between. This is most common in patients with fixed flow volume targeted ventilation. The 2 important causes of double trigger is the first one that I explained, that there is improper matching of the mechanical breath inspiratory time and your patient inspiratory time. The second important cause is insufficient pressure support in patients with high respiratory drive. So why insufficient or low pressure support will lead to double trigger? When you give low support, low pressure support, so this means low tidal volume, so the ventilator will end inspiration before the patient's own inspiration ending, and this will lead that the patient will immediately trigger a second breath with the same inspiratory cycle, leading to double trigger. How we can figure out double trigger in the ventilator screen? We can see the pressure time scalar, that there is 2 pressures consecutive to each others and 2 flow waves consecutive to each others. In assist control ventilation, it is called breath stacking, and it is frequent in patients with severe lung injury and increased respiratory drive. So how to manage double trigger? Because the ventilator inspiratory time is short, we need to lengthen the ventilator inspiratory time and make it matching to the patient inspiratory time. How we do that? Depending on your mode. If the patient receiving assist control ventilation like volume control, we should decrease the flow rate. This will slow the inspiratory flow and this will prolong the inspiratory time. If the patient receiving pressure controlled or SIMV pressure controlled mode, we directly increase the set inspiratory time from our setup of the ventilator, or increasing the pressure support on the spontaneous breath to give longer inspiration. If your patient on pressure support ventilation, you can decrease the cycling of flow percentage from, for example, from 30% to 10%, and this will longer your patient inspiratory time. The second maneuver for treating the double trigger, if the patient in assist control ventilation, you can shift him to pressure support ventilation, and this will give the chance for your patient to manage his own inspiratory time. And in this example, we can see clearly how the double trigger improved and resolved after we shift our patient from assist control ventilation to pressure support ventilation. The third maneuver to treat double triggering, we can reduce the patient respiratory drive if he has pain or agitation or fever or other causes. The second type of patient ventilator asynchrony is ineffective trigger or wasted effort, which is the most common type of asynchrony. What happens? The patient initiates an effort, however, the ventilator does not trigger a breath. Why is that? Because of two important mechanisms. The first mechanism is the auto beep. The patient effort occurs during expiration, and the effort is consumed to overcome the intrinsic or auto beep. The second cause is delayed cycling in patient with ventilator over assistant, means that you are iatrogenically giving your patient more than he needs. So the effort occurs while the ventilator is still giving inspiration. So this is simply the causes of wasted effort or ineffective trigger. Classically, the auto beep related cause, the patient efforts occur during expiration and the effort is consumed to overcome your intrinsic beep, so the trigger threshold will be never reached. The second mechanism is ineffective trigger by delayed cycling in iatrogenically ventilator over assistance. What happened in this cause? The pressure support you are giving to your patient is too high, and the tidal volume also becomes excessive. So this will lead that the ventilator inspiration will last too long, and the patient on inspiration will end earlier. So the patient will try to initiate the next breath while the ventilator is still in inspiration. So the ventilator cannot accept a new trigger while it is still giving inspiration, and the effort will appear ineffective or wasted. How we differentiate between these two causes of wasted effort? Simply, as we described earlier, that the flow time scalar in auto beep will not return to zero. However, in over assistant type, it will return to zero. The second, that in over assistant type, the tidal volume is high, more than 7 to 8 ml per kilo. However, it is normal or low in the auto beep type. And also the timing of the effort in the auto beep in late expiration. However, in the over assistant type, it is in late inspiration. How we figure out and detect ineffective trigger on the ventilator screen? We look first to the pressure time scalar. where there is a small negative pressure drip or dip that does not reach the trigger threshold. So if we see here the arrow, there is a negative pressure dip when the patient take inspiration and the airway pressure dropped, but here it will be less than the baseline beep and not reaching the trigger threshold. On the flow time scaler, we will see upward deflection towards zero in the circle of the pink scalar, and expiratory flow does not return to baseline, and there is no generated breath for the patient. How to manage ineffective trigger due to auto beep? We increase the trigger sensitivity by lowering the trigger threshold from 5 to 6 liter per minute to 1 to 2 liter per minute. As I described earlier, it will be easy for your patient to trigger. We should treat the auto beep and add external beep to be about 70 to 80% of auto beep. How to manage an effective trigger due to ventilator over assistant? We should reduce the pressure support. This is the first and most important step, particularly if the exhale tidal volume more than 7 ml per kilo. And second step is shortening the cycling criteria by increasing the flow cycle threshold percentage from, for example, 25 to 50% or 40%. And the button that we increase the inspiratory cycle of here in the ventilator screen. And this is the last slide that show if we increase the inspiratory cycle of from 25 to 50% after this red line, the ineffective trigger and wasted effort will be managed, and you start to see ventilator breath. Thank you.
Thank you, Dr. Wright. Thank you, Dr. Wright, for this nice presentation. And now we'll move to our second speaker, Dr. Ali. He finished his pediatric board certified, American board certified in pediatrics. And he's right now a senior fellow in pediatric critical care medicine in University of Southwestern Dallas, Texas. He's interested in his research in global health, education, and pediatric critical care in resource limiting setting. He will talk about the case scenario. So welcome, Dr. Ali.
Everyone, and thank you for having me. I would like to apologize if there's any background noise because I'm currently at work. For those who don't know me, I'm Ali, one of the board members here at Wickham in the Pediatric Critical Care Fellowship. I'm also one of the senior fellows at UT Southwestern Dallas, Texas, here in the USA. Today we'll do a case scenario over the next 10 minutes about troubleshooting mechanical ventilation, but more of a general concepts than anything else about a specific pathology. So I wanted to start imagining with me that you are sitting on shift on a call and you received a transportation call from an outside facility, an outside emergency room, for an accepting of a patient transfer from there. So you get called for a 12-year-old child with a history of moderate persistent asthma in adult ED that is in severe respiratory distress and unresponsive to the initial therapy. When you receive the call, the physician over there tells you, hey, we gave them the continuous albuterol, we put them on ipratropium bromide, we gave them already IV steroids, we gave them magnesium sulfate, does not seem there's any significant improvement. We had to put the patient on BiPAP, but the child seems to still, despite all of these efforts, have increased work breathing, paradoxical breathing, and altered mental status. So the gas was about 7.18 of pH, 78 pCO2, with an FiO2 of 60% on those BiPAP. And let's imagine those BiPAP settings are high. They have them on a PEEP of 12 and a pressure control of, let's say, plus 12. So that's a PIP of 24 non-invasive and a PEEP of 12. And the patient is pulling tidal volumes anywhere from 2 to 5 ml per kilogram. Now, the emergency physicians contacts the ICU for a transfer, noting the patient has progressively respiratory failure despite their maximum effort. They do not treat children in this ED, do not have the same experience, and they wanted to transfer the patient to you. Now, you say, okay, well, can you give me a little bit more brief history about the patient and walk me through what you actually did outside of that in your clinical exam? So they tell you the patient is a 12-year-old. He has a history of moderate persistent asthma. This is a patient who has, per mom, poor adherence to his controller medication. He's been requiring to use his rescue inhaler for at least every 3 hours for the past 3 days. He's very reluctant to come to the hospital because he's very much into soccer and he has a soccer season and he's taking it as a priority. He trains a lot in the past week, days, and nights. But he's reporting some signs of viral infection. He's having a runny nose, cough, congestion, and increasing shortness of breath. Now, they gave that patient the above-mentioned medications earlier on, but they also gave him ceftriaxone for any superadded bacterial pneumonia in the emergency room. You asked them about what are the current vital signs for this patient, and the ED physicians tell you, well, the last time I looked at the monitor was his heart rate was 190s, his blood pressure was sitting between systolics of 75, I believe the diastolics were 35, patient standing about 88% on that BiPAP 60% with a normal temperature. So you're starting to think, well, just remember the pathophysiologies. So this is a patient who's an asthmatic, who's from the signs is tachycardic in the settings of course beta agonist, but also from the stress, he is also hypotensive, and you can see more of a diastolic hypotension. So you're thinking of the causes of that from the underlying pathophysiology, and you realize two things. One, there's albuterol toxicity, right? There's a beta agonist toxicity, knowing that this will cause also hypotension and diastolic hypotension, but predominantly you're dealing here with a dynamic hyperinflation from that severe expiratory flow limitation in the settings of this asthma obstructive pathology, right? So you know that this patient is having increased intrathoracic pressure, which to an extent hinders your venous return, so decreases your preload, increases your right ventricular afterload, but there's hyperinflation of the lung, and also increased pulmonary venous return, pulmonary venous resistance. That's pulmonary vascular resistance, apologize, PVR. So you have a patient who's having less preload coming to it and a higher right ventricular afterload just in the settings of worsening air trapping and increased intrathoracic pressure. And you think, okay, well, this is the reason why this patient is hypotensive right now. While on the phone, you hear a discussion in the background and the physician is telling you, hey, a colleague of mine decided to intubate that patient while we're on the phone. They induced that patient with propofol and paralyzed him with rocuronium, and the patient arrested on induction, and they're currently doing CPR. They're not well versed in the PALS, and they would like your help with it. So what happened is you assisted the adult ED in running the PALS algorithm, how to do some deviation from the PALS, not deviation, additions to PALS in the settings of asthmatic arrest on induction over the transport call, and you were able to be successfully having a ROSC for this patient. So what happened, and what would you recommend in addition to the usual PALS? So before we do that, we have to take a step back and know that once you induce a patient, you know that there's a high, especially with propofol, you know that there's a higher likelihood of hypotension. And in a patient who's already having hemodynamic instability, compromised preload of the right heart, and you compromise that with additional vasodilatation and hypotension, there's a risk for cardiac arrest. Plus, you're taking this away, you're paralyzing a patient, and you're switching them from spontaneous breathing into positive pressure ventilation, knowing that the patient in their spontaneous breathing had already high intrathoracic pressure, compromising their preload, and you're switching that to positive pressure ventilation, which further hinders the right ventricular preload. This is also worsens that patient. So imagine having lesser preload, lesser venous return. So your cardiac output will be compromised because basically your left ventricle is not going to see much of the output that is coming to it. So that is the main reason that patient is arrested on induction. And it's not a common scenario, but it's one of the highest risks in asthmatic patients who are hemodynamically unstable. So the things that you are recommending to them is volume, volume, volume. Make sure you have a push and pull and you push volume in this patient of whatever fluid you like to just increase that preload to that patient to help something associating with a squeeze of the heart, improving your preload. Now reverse the paralysis. You want the patient to an extent to have some spontaneous breathing. So you would give that patient a Sugammadex, and usually 16 milligram per kilogram is what you want to give for an immediate reversible of rock. But the discussion is, of course, based on trains of 4, but in this settings, you want to reverse it with Sugammadex. In addition, you can also use neostigmine if you don't have Sugammadex. Now, in the future, maybe depending on what the patient have, propofol is actually a good drug to induce asthmatic patients because it's a bronchodilator as well, but only in hemodynamically stable. But if they're in a hemodynamically unstable patient with no prolonged septic disease, you can tolerate sedatives such as dexamethasone or ketamine. Dexamethasone, the biggest side effects of it is bradycardia. But ketamine is a bronchodilator, but the problem is it's sialyuric and bronchorrheic, so there's a lot more secretions with it. So there's a recommendation. In addition, you have to also evaluate these patients for tension pneumothorax. Air leak disease in the setting of severe obstructive pathology is something to keep in the back of your mind. Now, you also recommend for them to do continuous albuterol to make sure they schedule steroids and give it. They make sure that you can use ipratropium and you can continue to use magnesium sulfate, but there's a caveat to that. So ipratropium is predominantly not a bronchodilator, but it helps decrease secretion burden, but it also helps prevent bronchoconstriction. So whatever steps you access by bronchodilating the patient, ipratropium might help preventing further bronchoconstriction, but does not bronchodilate. Now, magnesium sulfate predominantly is a muscle relaxant on those smooth muscles around, so it causes that bronchodilation. But you have to understand with magnesium, there is a concern of hypotension, systemic hypotension. So the caveat is whatever drug you're using, you have to understand the side effects of it. Now, you would also recommend saying, hey, if you're listening to that patient and you're not hearing any air movement and you're saturated with your albuterol, you might need a different way of delivering that. You want to use the terbutaline. So it's an IV form of that beta agonist. Or you're saying, well, you're using both and you're oversaturating all of your beta receptors. Maybe I would choose aminophylline, which switches a different mechanism of action. And an easy access is just basically giving intramuscular epinephrine, which also helps as a bronchodilator, and you might even run them on an epinephrine drip. Well, to ask, so this happens and take the recommendations, and then the patient is intubated. We don't have much experience in running mechanical ventilation in these patients. Can you please further elaborate what initial mechanical ventilation settings? And I know there was an extensive introduction to this case, but without understanding the pathophysiology, the course of the disease, does not make sense to give recommendations on something without really going through that process and the mental model. So what you would usually recommend as a general concepts here, right? So you want to make sure that the patient is spontaneously breathing if the patient is tolerating it. So spontaneous breathing mode. You want to make sure that you have low respiratory rate to allow the patient to pace themselves and avoid asynchrony with the vent. You want to use not low tidal volumes, but you want to aim for basically the patient having tidal volumes between like 6 and 8. Some literature talks about 5 mLs per kilogram as well. If you want to prolong that expiratory time, you want to give them time for that to empty their breath, to empty their squeeze. At times, actually, you might do a manual, called a bear hug squeeze to empty those patients on their expiratory. And there's a query in the literature about minimal PEEP. Some people actually set the PEEP to 0. In the practice is you understand that this patient has high intrinsic PEEP. What you're trying to do is match to an extent their intrinsic PEEP or do a bit lesser than their intrinsic PEEP and aim for a bi-level to overcome that respiratory effort. So what you want to do is you, to an extent, match their intrinsic PEEP or around that PEEP that they already originally have versus having 0 PEEP, 2 ways of doing it. And then aiming for a plateau pressure of less than 30, less than 28. So to an extent also, there's some studies that tell you permissive hypercapnia in asthmatic patients who are intubated is good because it avoids barotrauma, it avoids hyperinflation, it avoids you causing more trauma to try to clear all of that CO2 that has been retained. And there's a correlation between rapid correction of the hypercapnia with mortality of patients in asthma who are intubated. So upon arrival to your PICU, it took the patients about 30 minutes, and they used an outside transport team, so you were not in contact with what's happening. The patient remained hypoxemic, and about saturation of 80%, and an FI2 of 60%. There is severe inspiratory, expiratory wheezing on the left side. There is absent breath sides on the right side, and the transport team reports that they had to adjust the endotracheal tube because it was too deep. The outside hospital was unable to administer terbutaline, aminophylline, but they were able to give intramuscular epinephrine. On arrival, the patient for you is tachycardic in 200s, blood pressure still low at 80s over 50s after receiving a bolus of LR, but the patient was kept paralyzed during the transport because the patient was fighting the ventilator, quote unquote. Well, you have to sit there and understand. So what is happening? You look at the scalars of the patient, and you see that the patient is shark finning on the vent. You see that the patient having escalation on the shark fin. You see that the FRC of the patient is increasing, and you're wondering, what am I looking at? And you are understanding, and this is, you're facing an air trapping, you're facing breath stacking, you're facing a ventilator asynchrony in a patient who's asthmatic. And the previous lectures went into details about this, and it's an amazing explanation on it. So now the case scenario here, we're talking about more what else can we troubleshoot, and systemic troubleshooting of this is going to be assessing for hyperinflation. So we do a manual, what we want to see first is evaluate for tension pneumothorax, right? Because they're telling you there's a diminished air entry on the right side. You do a chest x-ray for this patient. You see that there's diminished air entry on the right. You do a chest x-ray, you'd see a tension pneumothorax, or actually just a pneumothorax physiology. You can see here the line of the lung versus the air around it. So you want to do some maneuvers to assess this, and maneuvers you want to do is expiratory hold, which I'm going to demonstrate on a ventilator later on, measuring an intrinsic PEEP for this patient, which reveals an intrinsic PEEP of 18, which is confirming your concern for severe air trapping. Now, you also want to do systemic troubleshooting. You want to make sure there's a trial of the ventilator being disconnected. There's a brief disconnection from the ventilator with manual chest compressions, which what I said as a bear hugging that patient to facilitate passive exhalation. You want to optimize your ventilator as we discussed by increasing your expiratory time, making sure the patient is spontaneously breathing, having reduced respiratory rate, and then measuring your plateau pressure. In addition, seeing what you can do for this patient and monitoring their O2 PEEP. Now, this is an explanation of how to measure intrinsic PEEP and measuring how to measure inspiratory hold, how to do an expiratory hold, and what's a flow EE. That's explained by one of our respiratory therapists at UT Southwestern. So we have Sierra, one of our respiratory therapists here at UT Southwestern. She's going to help us demonstrate how we do inspiratory holds and expiratory holds. Go for it.
Okay. So you will first go to maneuvers, and then you will go to static measurements and click it. And then you will do an inspiratory hold. You'll just hold it until it beeps. And we normally hold it for about 3 to 5 seconds. And then it gives you your measurements, your plateau. And then same for expiratory hold. You'll hold it until it beeps. Normally for 3 to 5 seconds as well.
And the PEEP plateau is your O2 PEEP. Mm-hmm. Yeah. You were telling me something about the flow EE?
So typically when we have stable asthmatics come in, let me see if I can make it do it. There it goes. So if we think our kid is coming in and breath stacking, we watch our flow EE, and that basically is telling you that the kids, what we call air trapping, or they're creating auto PEEP. We like that number to be less than 3. So as you see here, we got the number up to 9, which means that we're going to want to either give the kid faster breaths or adjust our eye time to try to get that number to go down.
Okay, perfect. Thank you. I want you to understand that this is over a servo ventilator and you can be using a Drager or a different one overall. But this is how you can do an inspiratory hold maneuver to see a plateau pressure, and you can do an expiratory hold maneuver to see an intrinsic PEEP. This graph was further explained earlier, but basically in plateau pressure is the pressure that is seen in the lung versus a PIP, which is the assumed pressure that is giving overall to the lung, but you don't know what is reaching that lung parenchyma at the very end. So when there's increasing PIP or peak pressuring in an asthmatic mechanically ventilated patient, you have to measure your plateau pressure and see if there's a difference. And if the difference is less than 5, then the patient is actually seeing the high peak pressures. The lungs are actually seeing the PIPs, and that could be hyperinflation, asynchrony, pneumothorax, or an actual parenchymal disease. But if the PIP and the peak pressures have a difference of more than 5, you're starting thinking of more obstructive pathology, worsening bronchospasm, mucus plugging, or there's any occluding in your endotracheal tube. Anyway, I hope you benefit from this, and the major take-home points for this is preparation is paramount in intubation in patients with asthma. There's a high likelihood of arrest in patients with asthma. Ketamine, benzos, or propofol, if hemodynamically stable, is very useful when intubating asthmatic patients. You have to understand the initial ventilator settings that you're using for those patients, and understanding an underlying pathophysiology of this disease to be able to troubleshoot where your patient is, and keep an eye on the patient's expiratory flow, keep an eye on the patient intrinsic PEEP, and keep an eye on the patient's breath stacking. Thank you, and if there's any questions, please let me know.
Thank you, Dr. Ali, for this case scenario about the troubleshooting and patient and ventilator. Now we'll go to the question and answer, and we will concentrate the question that related to the mechanical ventilation and the troubleshooting. First, the two presentation talk about the servo eye as a ventilator that the modules presented, but it can be in most of the ventilator available in the market. First question, we hear in Dr. Ryan, Dr. Ali about the PEEP, auto PEEP, intrinsic PEEP, and extrinsic PEEP. So what's the difference of those PEEPs and where to use them? Dr. Wright, please.
Yes, thank you, Dr. Turki. Actually, the extrinsic PEEP is the applied or sit PEEP. This is what the physician will sit in the ventilator. It is called the extrinsic PEEP or sit PEEP or applied PEEP. And this is what we usually use it as ICU physician to prevent atelectasis, alveolar collapse. We use it in ARDS and asthma patient and etc. This is called the extrinsic PEEP. Sorry. So what happened during the process of mechanical ventilation? Iatrogenically, we may introduce intrinsic or auto PEEP. How we do that? If we are giving too much minute ventilation, we are using too fast ventilator rate or too much tidal volume. And this will cause what is called auto PEEP or intrinsic PEEP. That happens, it is a pathological PEEP that either from our practice in the ventilator, as I mentioned, or from the disease process like asthma. Still there is ongoing bronchospasm. There is there is too much retained air and volume at the end of exhalation. So this is the auto or intrinsic PEEP. That the total PEEP is the PEEP that we measure it by the expiratory hold. And I show in my slides that when we did expiratory hold, in the screen, the value will be the total beep, and we subtract it from the set or extrinsic beep. This will measure the intrinsic or auto beep, which is pathological, that we need to treat it either by ventilator maneuver or by medication bronchodilators.
Okay, thank you. Second question. You mentioned, Dr. Wright, about patient ventilator asynchrony. So how I know that my patient has asynchrony with the ventilator and how we treat it?
Excellent question. Of course, the first thing is clinical evaluation and clinical assessment of your patient. And I clearly showed simple modified approach using A, B, C, D, E. So A, first assess your patient. So if we have patient ventilator asynchrony, the first thing will appear is the clinical manifestation. The patient will be distressed, although he is in a ventilator, he can be tachypnic, tachycardic, desaturated, using accessory muscles. He's unhappy on ventilator. This is the first sign of patient ventilator asynchrony. Then we will go to our graphics that I show. We should look to pressure time scaler and flow time scaler and the loops, which is the volume pressure loop and flow volume loop. And from there, we can figure out whether the problem is double trigger. We will see two consecutive breath together from the ventilator, or we can see that there is upward deflection in the flow time scaler without any generated breath, which is the wasted or ineffective effort. And from there, we can treat according to the specific type that I explained.
Okay. Last question because of the time. You mentioned about the peak respiratory pressure, and you saw the graph also. Sometimes it changed and became so high. So what could be the cause and how we treat the increased peak respiratory pressure?
Very good. This is also very common alarm and very common problem encountered in the ICU. If we have high peak inspiratory pressure, which is the PI, and alveolar pressure, which is the blood pressure. So the problem if we have high PI or compliance problem, how we figure it out? Very simple, by the NSB. So we press the inspiratory hold for 3 to 5 seconds. What we can see in and we compare it with the PIB. For example, the PIB is 30. However, the plateau alveolar pressure is 20 or 15. So this means that the problem is in the airway, which is usually airway resistance like bronchospasm, secretions, or kink. If we did the inspiratory hold and the peak inspiratory pressure, the PIB, is equal or near the value of plateau pressure, example, PIB is 30 and the plateau is 27, 28. So this is a lung compliance problem like we face it in patients with acute lung injury, ARDS.
Okay, thank you, Dr. Wright. Thank you, Dr. Ali. Now we'll go to the close remarks with Prof. Amr. And there is Dr. Amr. There is many questions about the fellowship and how they register. And if you can also answer this, please. Thank you.
Yeah, absolutely. Thank you so much, Dr. Raed and Dr. Turki, for this fantastic presentation and wonderful discussion. Yes, I see that there is a lot of question regarding both the pediatric cardiology and the pediatric critical care fellowship. So please visit our websites. Here is a pediatric cardiology landing page link, registration link, application link. And if you have any question, you can either email Ms. Norhan or email myself. Here are our email addresses. So please don't hesitate to contact us. We also have your contact information. We are going to share with you, hopefully by tomorrow, the recording of this fantastic webinar in YouTube, and you should receive attendance certificate of this webinar within this week. So hopefully you enjoyed this webinar, and we will have another webinar next month. We'll announce it, so please stay tuned for further information about our pediatric critical care and the pediatric cardiology webinar for the next month. Thank you.
Thank you.